I think that we can get started. Today's agenda really, is the next in this cycle of activities. So the first thing we're going to do is return to our last session and look at those decisions and clarify a couple of them and make sure that those are sounding reasonable to us. Then we are going to move to three, I think, very interesting sections. The first on the role of regional entities, what their structure then should be in the next section, and what their relationship with the single payer should be. And as you'll see, I think we've tried to consciously, at one point, it's quite a conscious choice to set this up as we've got a continuum here. And where in this continuum should the regional entity be, especially as it relates to the flow of funds and money and the control of money. Essentially, the insurance piece, if you'll pardon that generalization. With that, I'll turn it over to Janine. Are you going to run this ship?
Yes, lucky me. Laurel didn't want to, no, I'm just teasing. So let's,
well, I can get us going with this values piece,
okay,
because this was my homework, as I recall. So last time around, we shared a draft of the values that really attempted to pull in pieces from 770, but also some other language that was pulled from other places in statute that tried to get at some core values that we heard in your first meeting. At the last meeting, there was a kind of a reflection that verbose values might be counterproductive, essentially, that it's better to be succinct in these value statements because it really gets at the core purpose here. And we actually had accidentally created a slide. I mean, we created the slide on purpose, but it included abbreviated versions, and you all kind of reflected back, actually, this slide with the abbreviated versions is kind of more in line with what we're thinking. And so I pulled together these abbreviated values. One thing that I was really struggling with, however, is when you look at just these 5 sentences, I worry that there's not a clear focus on addressing health inequities. And so I attempted one way around that, this component, which is taken from section 3 of 770, it seems to kind of operationalize health equity, or rather may not create barriers, or may not create barriers or disparities. It seems to kind of operationalize that concept. So instead of kind of having a vague statement about health equity, I wanted to propose including this language so that, 1, 2, 4, and 5 are more succinct, but this number 3 here is more robust, and that seems to be in line with the values that I've heard from you all. So this was my proposed updated version, and I wanted to offer these 2 different versions so you could see what I was grappling with here.
Comments? I want to say, as I looked at this, I love this. I just think it's great. I'm okay with the more language version. I also looked at it, is it in the right sequence? Not that I want to say these are priorities. They're not. I think they're all equally important, but the sequence makes sense to me in a variety of ways. So this works for me.
Yeah, I like it a lot. It certainly makes clear the intent. I think the only thing that gives me pause is in the last sentence of the paragraph you just dropped, Laurel, where it says, nor disparities in health outcomes due to access. For me, that means that it's okay to have disparities that are due to anything other than access, right? Because sometimes because you access care doesn't mean that you're getting the quality or the appropriate care that you need, particularly if you're marginalized and BIPOC. And so that's the only limiting factor I see in relating the outcomes simply to access.
Deborah, this is Chad. Is your issue the word nor? Would it be better including
No, I think that, you know, to end it at outcomes and not attribute the disparities only to access would actually better suit my concern, to take out due to access. Because we have folks who are accessing care that's not responsive, that's not language or gender appropriate or affirming. So it's not just whether they can, you know, get the care, it's what kind of care is this new system we're building actually going to be required to deliver.
Yeah, I understand.
I'd be in favor of changing nor to or and doing what Deborah said, is just ended at in health outcomes, period. So it would read, may not create any barriers to health care or disparities in health outcomes, period.
I support that.
So I wouldn't want to go back to 7th grade sentence diagramming. I'm a little concerned about how it goes.
You're on mute, Chuck. You're on mute.
Sorry. So I wouldn't want to go back to 7th grade sentence diagramming, but I'm a little concerned about how it reads with religion or sex, comma, including sex stereotyping, gender identity, sexual orientation, and pregnancy. I don't know if the and pregnancy is and related medical conditions, including termination, may not create. I think that part is sort of awkward on it.
So this is just as context. This is pulled. Okay. This is pulled directly from 770, which I went back. And I believe this is the language that is used in anti-discrimination statute in the state. And so there's an attempt in for consistency there. Doesn't mean that you can't divert from it, but that's as context, that's where it came from.
Okay.
So I'm sensing there's a consensus with the changes Bruce mentioned. I would move to the next section by saying, one thing I would hope is that any subsidiary contractor that the single payer works with would adopt these same values. And a condition of any relationship the single payer had would be, you must adopt these values, and we must be able to see these, you know, alive and well in your organization. Okay.
All right, so you all got a summary that we sent out with the materials. That is, we didn't copy that all onto the slides, but wanted to ensure that you have it in front of you or have looked at it. And then we wanted to kind of go through, we had identified a couple areas we wanted to clarify, make sure we heard you correctly, and see if there were any other clarifications or adjustments you wanted to make. The first one was roles, and under roles, we wanted, it was up on our slide deck last time where we said set utilization control policies. And we didn't know if you wanted to have we didn't have much discussion, none that actually Janet and I could remember specifically about that. But we didn't know if you wanted to add more language to that area this time or not. And then is it sort of centralized in the role of the single payer, or will it be dispersed or a combination of both? Just wanted to get a little bit of thoughts there to see if there's enough there with set utilization control policies, or if you wanted to augment it at all.
Could I suggest that maybe we consider that when we talk about the role of the regional entities?
Yeah, I think that's the agenda for today, really.
Okay. And other thoughts from anyone? So for the,
I mean, I just think it's a combination of both.
okay.
And there's a set of, I think, policies that the single payer would hope would go across and be standardized across, all the regions. And then there would be others that there would be some variation that would be, reasonable, that would be more decentralized.
And Deborah, did you want to say something, or you were putting your thumb up for agreement?
Yeah, no, I was in agreement with the both and, right?
Okay.
There will be things that are constant, and there will be things that will be specific to the regions in order to get to that the responsiveness to local community needs.
Okay. So we can look back at this as we get through today, and we'll be coming back around next meeting on the regional decisions and see if we want to make any changes in that roles line. The other, were there any other issues at all under the roles portion of that one, maybe 2-pager that we sent out to you that anyone identified? If you remember, that section had apply the reserve powers, unique to the single payer for financial management and stewardship, oversee program administration, develop and implement program policy, support delivery system reform improvement, achieve health equity to improve access, quality of care, support workforce development, and develops and maintains the population health-based information system. So any other edits, adjustments at this point for this?
Yeah, I just want to make sure that all of this is still subject to the rulemaking process for public comment.
You mean as they implement their roles, or this document per se?
No. As they're going through creating the things that are outlined in detail that are only bulleted here. So yeah. For example, when it says, let me scroll back up into it. When they talk about, some of the administrative things, when they talk about developing a program policy, because these will be state-wide programs, if we're talking about it from the hierarchy, that these things aren't just made between CCO or regional models and their administrators, that at some point, in order to make sure that the things that they're creating are responsive, that there is some engagement that goes through a process similar to what we currently have.
So I think we had, and that's one that goes to our structure as a public corporation. I'm not sure myself, and maybe others are more clear, the obligations of a public corporation for the similar rules process that the state agency has versus not.
Well, I think right. In creating
and again, I guess I'm getting to the fact that since this is a state program, right? This will come from state revenue, state funds, that it's more of a quasi public-private partnership than for it to be on its own and independent of those same kinds of protections and guardrails and inputs.
Right. I mean, I've been operating under the assumption that we can decide whether it's, and I would hope we would say it's subject to public meetings law, public records, and the Administrative Procedures Act, which is what governs public comment on rulemaking, that it can't as a board just decide certain rules without going through public comment like other agencies have to.
I mean, I was anticipating we at some point would have a specific discussion on transparency.
Right, I agree, John. And Chuck, I think that we should presume that all of the transparency elements of the state would apply to this entity.
Yeah, and potentially more.
Potentially more.
Yeah, I mean, again, I would hope that any organizations that we have relationships with meet our standards when it comes to transparency.
And also that would apply to any subordinate organizations at the regional levels as well.
Right.
So do you feel like we need to add a role here, or do we want to make a note of that, those observations perhaps under the structure as the structure gets determined?
Janine, this is Laurel. I just saw a thumbs up from Deborah. I'm thinking that this could be something that I think we've gotten kind of the general sense here, and we have a meeting, I believe it's the next one that we're hoping to that we have some space, that we were going to dive into some of the fiscal elements.
Yeah.
But there's also some space on the agenda, and I might propose we can kind of set some side of time to be talking about transparency as John proposed.
Okay, everybody okay with that? Yep, okay. So then the other question was just whether everyone, there was a lot of comments positive about it being a public corporation. You'll notice we wrote it as consideration of a public entity because we hadn't heard it 100% in whether you want to leave it that way for now and talk further, or we have a little more space. But that was our, did you all agree it should be a public corporation?
You know, from my standpoint, it should at the very least be a not-for-profit organization. I don't know about public as well. I don't know.
Yeah, Bruce, do you have a comment?
Yeah, I was going to say, you know, I think, and our discussion was we want this to be nonprofit, public. I mean, I think there's a lot of different, I guess I would be comfortable saying we want it to be a public entity.
Right.
I think public corporation denotes something very unique and specific to Oregon. And I'm not sure we all totally understand what that means, and perhaps saying that this is a public entity. And I think we could probably use some more work, perhaps if we get an extension with actually some legal input about kind of legal entity frameworks, I think might be more helpful than just saying it's a public corporation.
Yeah,
Okay.
I agree. I mean, you know, actually, you know, Bruce and I talked with Governor Kulingoski about this, and he said, well, we have different, public corporation doesn't mean one thing. You have OHSU, you have OPB, you have SAFE. And then, you know, I actually just recently looked up the lottery. It's not called a public corporation. They refer to it as a public trust with a business plan, right? Business driven or something. And so I just think we should say a public entity with all the public transparency aspects. You know, the people who work there are probably going to get PERS. They should be subject to public records law, open meetings law, and APA and all that. So at this juncture, we should wait till we get the legal advice of what we actually call it. My understanding is public corporation is sort of, it's how the legislature defines it at the point they create it.
Okay.
You could also talk about ownership by the residents of the state of Oregon or something.
Right, and 770 refers to it as a public trust, right?
Right.
And they may have taken that from the lottery language. I don't know.
Okay.
I asked that multiple times, and I never got a clear-cut answer. I'm not sure it came from anywhere. I think that was the language that they ended up with.
So we hear you, and we will adjust that statement of consideration of a single payer entity to be a public, to all the open.
Public entity, transparent, fully accountable to the people of the state of Oregon.
Yeah. Yes, all of the above. All right, we will make those adjustments. And then the last, we didn't have specific questions about the board section, but just wanted to ask if there were any adjustments to that language that anyone wanted to make. We described the membership. John augmented a little bit to make sure that the conflict of interest was not only when you selected, but during the time you served, and perhaps a time after, to be TBD. And we left it as reimbursement for their time and left that probably to be further discussed. So any issues with that area?
The only question I have is a question maybe for Chuck, which this defines as to require governor appointment and Senate confirmation. And I just wonder if that, given the structures that you've alluded to, whether that is a bit on the narrow side. I don't know.
I'm not sure what you mean by narrow, but the public corporations we have, there is governor and Senate appointment.
So
and Senate
they
approval.
all are.
Yeah.
They all are in the same manner.
Yes.
I don't know if I think they all are, but they can't. I know at least one of them is. Yeah. And I don't think the governor now appoints all the OPB people, but I think the governor does appoint
some are
SAFE.
just governor. There are entities that are governor appointed only. It's a little double check to have the Senate be part of the process. That's what I believe SAFE was, and that sort of thing. So. All right, so we will move on to today's work. So we provided you a little more detail on each of these, but we just wanted to touch on a selection of regional entity structures to think about as think about what you would like for the regional entities here in Oregon under this model. So many of you some of you are probably familiar already with the Central Oregon Health Council. It actually developed prior to the development of the CCO in that region, but now serves as its board of directors. It is a nonprofit, tax exempt. There are some investments that they help to direct that come in from the quality incentive funds. And they are really working across the community. They've been in existence since about 2007 or so from they had some other names initially. The other regional approach, some states have actually built upon, which is the Accountable Care Organization, which evolved out of the Affordable Care Act and some of the efforts to do more alignment around Medicare predominantly, although there are some commercial plans that also have ACOs. Their efforts are to coordinate high quality care or under some value-based payment arrangements. Most usually they form primarily to get into some of the various Medicare ACO value-based payment opportunities. There's a lot of variability about these and how they're structured. Some have built up from IPAs. I can never remember the exact, interphysician associations have evolved into ACOs. Their funding source is shared savings, and they're sort of voluntarily have come together with providers, hospitals, other healthcare providers, and they share financial and medical responsibility for providing coordinated care. Some people nationally get confused whether Oregon CCOs are ACOs, but we're not. We're unique here in Oregon. But many of the providers that are participating in CCOs may be part of a Medicare ACO. Healthy San Diego has been around for some time. It's localized to the county of San Diego. And is based in the county government, and it oversees local Medicaid managed care system. It has a contract with the state Medicaid agency, and also applies county funding. It helps members to get enrolled, their citizens of the county to get enrolled in their health plans, a very big focus on managing special populations, convenes stakeholders, and works on collaborative health improvement activities, aligns with public health and managed care. And then the Greater Detroit Area Health Council, interestingly, has been there since 1944. It is a regional healthcare improvement organization, so an older model, non-exempt, tax-exempt, primarily exists off of grants and dues, and allocates, tries to make sure that everything is allocated cost effectively, and best use of healthcare resources in the area. A lot of data analysis and reporting, focus on other things, including education, employment, and empowerment, and a focus on special populations. I think, any questions about these particular? I think we have another slide of a couple more.
Just a comment on I, at some point in time, would like to see information on governance and their approach to governance and membership. And that, for me, is a central issue to these regional entities. So just put it on the side, we can come back to it.
Okay.
Yeah, I think what's triggered for me is that it's nice to see these sort of, for context, but I guess my bottom line is which ones have been, more successful, and if they have proven some higher level of efficacy, how similar are the populations they're serving to the ones we need to serve, right? I mean, if these are all based, like Detroit's a super dense urban city, I've worked there, that's not like frontier Oregon, right? So,
right.
I would need to be able to make that kind of comparison before I can, really try to discern whether or not these models might work here.
Bruce?
I'd like to get a better sense of these are all great, but I'd sort of like to get a better sense of what we're envisioning the functions are. And that would help me then think about governance and other issues. And I'm just wondering if, Chad could spend a minute talking about the role, some of the role that was envisioned for the regional entities in the provider reimbursement tag.
Yeah, I think we're going to get there.
Okay.
We're going to get there. Chuck?
So I was like Bruce, but I also am wondering which ones would best fit, how they would fit with our certain values. So for our values, transparency, that's at least as good as Oregon's, which is very transparent state laws. I'm not so sure a nonprofit is the right way, right? If it's for involvement in rulemaking, if we're going to have, as we started at the beginning of the meeting, some policies at the state level, some at the regional, we still want that input at the regional, right? That Deborah talked about. So I think that analyzing them according to our values, which can best meet our values, is the.
And probably it's a slice and dice. You take elements of these various kinds of things.
I think it might be best, Janine. I think you do have another slide with additional organizations. I think we envision this as kind of a, high level view, in part establishing that it's doable to do a regional organization. So go ahead, Janine, and finish with this slide.
Many of you are super familiar with coordinated care organizations. They started in 2012, and I won't go into the details there unless anyone really has questions about them. But there are some obligations beyond just providing Medicaid services, but they have to conduct community health assessments. They need to improvement plans. Work with their community. They're trying to work across and improve the community, not just for Medicaid lives, and then work with and develop transformation plans especially in behavioral health and in integrating traditional health workers. Accountable communities of health is Washington State's, I wouldn't say they're their version of coordinated care, but it's what they did with their waiver, where they have about 5 managed care plans across their state. They're not necessarily local like our CCOs, and they're multiple sometimes in some areas of the state. And so the state wanted to set up a body that would help to coordinate with the community and align the healthcare systems and the local communities together. They started in 2015 with some investments. They're all nonprofit, and they're funded initially through a large federal grant called the SIM grant, and then some dollars through their waiver. Unfortunately, those dollars are going to be running out here in the next year, but they have worked on particular projects around health equity, coordination around social determinants, assessing regional needs, somewhat similar. One ACH in one part of the state is not the same as another ACH in another part of the state. They are currently all working to understand where their future is going without the SIM grant is over. The Medicaid transformation funding might disappear. They were being held to clinical metrics, which is hard when they had multiple Medicaid managed care plans in their same region. But there are some good examples there of trying to work on a regional basis. And then New York State, similarly, and a lot of Washington's work is based off of what New York had already had in place, where they have what are called PPSs, or performing provider systems. Their partnerships and collaborate in delivery system reform initiatives. They were also funded through Medicaid, what they call DSRIP, delivery system reform incentive programs. Unfortunately, they asked for a renewal recently from CMS under the last administration and were denied. So they are currently trying to sort out where the future is here as well. But their goal was to reduce avoidable hospital use by 25%. They were getting close, but they wanted more time. So it looked like the March 31st was the end of the DSRIP this year in New York. So it'll be interesting to watch. They are trying to move towards value-based payment, but I'm not sure if all of their PPSs will exist or continue going forward. So, and the background materials have more links about these various organizations. So that was just a lead in, as John said, just to kind of show that there are varieties of regional entities out there, and they're picking what best works for Oregon is sort of the next charge. Any questions about these three before we move on to the role of regional entity?
One comment, and that would be that, of course, none of them are as expansive and universal as what we are anticipating here. So some cover Medicare, some cover Medicaid, some handle the money, some don't handle the money. I think it's a good overview, but other than giving us ideas, I don't think there's anything we can model ourselves after here.
Right.
Chuck?
And I've been sort of thinking about them being, what we're creating being sort of what I think is like in the watershed area. There's a state watershed council that has gets money and whatnot, and there's 5 or 6 regions. I mean, I see the regional entities being sort of the children of, because they have to be accountable to the state one, and governed by the same transparency stuff, right? And so, as far as governance goes, do they each get a representative on the board of the state one? I don't know, right? All that, but I see them as more direct versus separate like these from any state agency.
All right, other thoughts? So otherwise we'll move into Janet, anything you wanted to add about these? Okay. Janet did the research on these, so I wanted to give her due credit. So regional entities roles. This was what we have here is really what came out of the provider tags proposal that was approved by the task force in March. They would have delegated authority from the single payer to manage, implement, coordinate care for the region, which would include, and so what I'm showing you today, right now, is what was in that proposal. And then our next slide, as you will see, is some revisions that we discussed with John of kind of where he might want to have the discussion go. What was in that document was receive and manage a global budget, contract and establish methods for reimbursing providers, do some regular regional planning process, working with stakeholders, especially around the areas of prevention, chronic conditions, and then manage a budget for exceptional medical capital and critical infrastructure projects. So shall we go to the next slide, John, and then show what, so John took my slide, and which was your proposal from the provider group, and added some other language. And basically it's changes things a bit in the sense that the regional entity would be more of an advisor to the single payer, who are the ones that are in the single payer would be managing, implementing, and coordinating the overall care. They would be advising on the global budget. They would be advising on the contract and methods for reimbursing the providers. They would, of course, be integral in ongoing community and stakeholder convening, as well as the regional planning process. So it wouldn't just be a one-time regional planning thing, but they are there on the ground with the region. They would advise the single payer on the budget for medical capital and critical infrastructure, and then continue to assist and advise providers on ways to improve the delivery system, promote collaboration at the regional level across the regional delivery systems, and then discuss with the stakeholders in that region where the community and capital investments should be. So you can see it's a little bit of a twist from the original thing that you approved.
Right, and so this is the continuum that we really wanted to set up. And, you know, to cut to the chase, it's about the money. I hope this is okay, Janet, but in our discussions, Janet reminded me of the golden rule, which she defined as whoever has the gold rules. You know, I simply would have a difficult time, you know, delegating 85% of the money, 90% of the money to a regional entity, unless they were a subsidiary. If they were a, you know, wholly controlled subsidiary, well, then that's doable. But you know, what I have been so impressed, and actually I really appreciate the Central Oregon example, because frankly, I didn't realize how unique that was. I did realize that Pacific Source had a very interesting relationship going on there, and significantly provided a significant predictability in terms of the insurance component there. You know, I'm impressed that Oregon has really tried to reach out to communities, to give them ownership, to give them access to real resources. You know, while the Eastern Oregon CCO is very different from Central Oregon, I've been impressed when I've been in their region that you know, they have created loyalty and support there and understanding. And some of that is based on their ability to assure the community we're going to be treated fairly. And the resources are going to come here. You know, they're not going to stop in Portland and have some bureaucracy take, you know, 20% of them. And so, you know, I mean, I see this relationship as critical and as a very close relationship. I'm not sure how many of the CCOs would move from what they're doing now to this, but I think a lot of them could. And so really this discussion is getting a sense of from you all of, in this continuum, where should we be?
So I think I saw Bruce's finger up.
Yeah, I just had a question. So just to be clear, previously, the provider payment tag recommended regional entities that I would paraphrase would contract with and pay providers, as well as probably do utilization management. And in what you're suggesting, John, it's something different, that the single payer would contract with and pay providers and probably do utilization management. Is that correct?
Well, I would say definitely the single payer would hold the contracts, would pay providers, would have the community organization at its side. When it came to utilization review and quality management, I would see that as shared. I would see the single payer setting the tone for that, but each regional entity, I think, there would be some variation there. One, because my sense is oftentimes in one region, their big utilization issues, quality issues are very different from another region.
So just to follow up, just to be clear, there would then be no regional global budget. It would just be a statewide global budget. Or am I missing something?
Well, there might be a regional global budget, but the money would go from the single payer directly to delivery systems and would not go through an intermediary.
Got it.
And you know, part of my purpose here is just, you know, we need one less bank in this process. If you're going to be sending, you know, $45 billion out to 6 or 7 different regions, it's going to cost you 2 or 3% just to send that money out and have it go through an intermediary. And frankly, I don't want to lose that 2 or 3%.
Thank you.
Other thoughts about whether you want to go with John's adoptions, or Chad?
Yeah.
Where to start? You know, it seems to me that that we do want to maximize dollars going to the delivery of care. I don't know that that's in our values, but certainly it seems to me that that should be part of our values, that we want to maximally move money down to the point where care is actually delivered to individuals. So a lot of what I see here and what John amended doesn't really particularly give me heartburn, except I worry that that we want to be careful not to sort of make these regional entities unimportant and insignificant, right, and not impactful to the local areas. I think that's very important.
Right.
And if we're not careful here, this is going to be seen as a statewide program that sort of has a few people sitting on the periphery that can pipe up and may have something to say about it and it may not. And I think that could be very damaging. Well, I think it could be damaging to the acceptability of such a plan that is just being approved. But furthermore, I think could be very damaging to the notion that different parts of the state of Oregon are very different. and they have different issues, and they have different approaches. Some have tribes, some don't have tribes, some are rural, some are urban. There's a lot of difference, and so I think that it's fine for the state to be the fiscal party, but I think it's very important that the regions have a very active and involved voice in how it works at the region that we're talking about. And in particular, I think there is a need for the region to have some strength, for it not merely to be sort of another advisory board, but it has some strength in the statewide process, because otherwise providers will move right past that group. They'll know they don't have anything to say about it. They'll go straight to the state, and pretty soon we have no regional entity at all. And so I'm looking for that sweet spot. I'm not looking for another insurance entity. I would agree. I don't think we need another entity that is quote unquote at risk. But I do think that we need a way to have these regional entities be material and be robust and be represented very broadly by the people that live in that region. And so I guess I'm trying to have my cake and eat it too. But I worry about just kind of an advisory role, because I think that is a prescription for what is seen as a statewide program that the region's really got nothing to say about it.
So I know I see Chuck's finger up, but I think Sam also had his hand up prior to that. Did you want to talk?
Yeah. Sam, we're not hearing you.
Yeah.
Okay.
So what? Okay, we'll go with Chuck next.
Yeah. So I think you're spot on, Chad. For me, I think when I read this and listening to John, I think we need to come up with the language of what does the statewide entity have to do, not just take the advice. It maybe shall follow the advice, some language about following the advice. And if it's going to deviate from the advice, it has to make these type of findings or whatever. And so I think it's describing, we have to come up with language describing of what the statewide entity has to do with that advice, the extent to which it has to follow it or whatnot. Because I see I envision, okay, we're in the program, and all of a sudden the statewide board says, hey, let's try a pilot project of doing with this type of workers' compensation injury or whatever. Let's try it out, and the different regions, come up with pilot project grants or whatever to certain providers. They would, they could maybe dole out that money and make that decision on that. They would say, we advise that you give it to this provider for this pilot project. And that would be one that the statewide entity would have to say yes to. The money would come from the statewide entity, but the review of it and all that would happen at the regional level, right? And it may be, but bigger things, this would be a different standard for what they do with the advice. So I think that's the language I think we need to come up with on the other side of the equation.
So I see Bruce's hand up. Sam, do you want to try and talk? Try one more time.
Can you hear me?
Better.
Excellent. There are two lessons from Oregon CCOs that I think we should keep in mind. One is we ended up with competing CCOs, competing regional entities that were trying to undercut each other. We don't want that in our regional entities. The other is that the business association between CCOs in Oregon was so loose. One of them was purchased by a for-profit out-of-state corporation. Both of those we should avoid in our design of the administration of the regional entities.
Right, and I think we're going to get to some of that a little bit later to make those discussion topics. Bruce, go ahead.
Yeah, I agree with what Sam said. And also, I like the way Chad framed this. I think we need to we don't want another administrative entity that adds little value, but you do want to have a strong voice for regional and local issues. You know, perhaps there can be some sort of, you know, and this gets at, I think where we need to go is governance, that ultimately could there be some council of regional entities which has to approve global budgets and contracts or something like that, that would give them some, you know, some power, but not a lot of administrative overhead and bureaucracy. But they would, as a group, need to, in essence, sign off on the contracting and on the global budgets. And that would probably give them what's needed in terms of looking for that spot between being important, but not another layer of bureaucracy.
Others' thoughts on that concept? Sam, his hands is up again, or Deborah, did you have anything? No. Sam?
No, I'll take my hand down. Sorry.
Okay, Chad, and then John. Chad, you're on mute.
Sorry. The vast majority of monies that will flow need not have the fingerprint of the region. It's really more of an ability for the region to tailor these entities to meet their particular unique requirements and have some ability to create some incentives for innovation and creativity at the local level. So, I mean, it seems to me you can sort of do both of these, because the vast majority of money that goes to a hospital or goes to a provider need not really have an active participation by the region. I'm with John on that completely, but I do think that there is, and others have referred to it, I think Bruce kind of alluded to it, this idea that we do have some sort of bonus pool or some sort of incentive pool or something at the regional level that is not immaterial, but not out of proportion, but allows that local entity to tailor these things more suitably to meet their needs. Because I worry that all of the language that we've referred to about ethnicity, about these individual groups, I worry that comes on high from the state. That's not a good prescription. I think it's more important that some of those things be tailored at the region that's experiencing it.
John, did you want to add comment here?
Yeah, a couple things. I mean, first of all, I see extraordinary transparency here. And so I think in an environment of extraordinary transparency, a regional organization would know much more. I think one of the problems with a monolithic a monopoly is they don't share any information. And that would not happen here. The single payer can't, hide information. A second, I think, issue is what Sam gets at. I think saying it directly might be best. I don't think we're talking about an approach that is relying on competition in markets here. It's relying instead on collaboration. It bothers me sometimes to think there's a region with 3 CCOs, and because they're competitors, they're not sharing innovations that are working. Instead, they're keeping those to themselves and competing. And I admit it's going to be a challenge to move some regions that are very competitive to collaboration rather than a competition. Chad, you're on mute.
Well, I was going to say to elimination, because I think that you've got competing CCOs in an area, and even if the CCOs morph into this regional entity, in my view, you don't want 3 of them. There's going to be one, and the other 2 are going to go away.
Right. The other thing is, I think the single payer is going to need a partner in a region to sit down and say, hey, we need more of these types of workers. And they're out there, but they're not organized. One of us needs to organize the community workers or the interpreters, or, we've got, there's a system of alternative care providers, but they're really disorganized. And, the medical model folks are not interested in organizing the alternative folks. So somebody's got to organize them. So, I see the regional group as being a partner who could get that done, because they're on the ground, they know the ground, and they can get those kinds of things done. And I would hope we could figure out a way that, these organizations would be nimble, would be able to get things done, be able to be transformative. And I know that's a bad word for some folks. I think if you look at the principles that we have, Chad, I hear you. I think because, when I was in Eastern Oregon, they made it clear, there's certain words you want to use here, and there's certain words you want to avoid. We like to hear that we're getting all the money, and we have, discretion around how all the money is going to be used. When you say single payer, but, from an equity point of view, we have to accomplish that. And frankly, in some places, we may have a delivery system that, isn't able to do that. And we need a partner to do it. Be able to do it in a region. So that's where I'm coming from.
So I was going to suggest something and see if this at all works, considering this conversation, is where it says advise on global budget. Should we say advise and work with the single payer to approve the global budget? Should we say advise and work with the single payer to approve contract, or something to that extent? Would that be something, or do you want to just take these words as they are and then further define it in a different way?
I'd suggest keeping it for right now and moving on when we talk about governance to figure out how to create a governance model that gets at some of this. I think the words are fine to me, but I defer to others.
I put it off as well. I think that I could imagine a circumstance where staff comes back and listens to this conversation kind of more carefully and thinks about how to best tailor the language. I would hate for us to get caught up in spending time today on tailoring the language.
Okay, so we'll go with this. Deborah, did you have any other? You're good? Okay.
No, my thumbs up is it when I'm in agreement.
Just double checking. All right, so we'll go with past this slide, leave it as it is, go with the red version of this.
Wait, Janine, sorry, this is Laurel. I just want to make sure that I have clarity on the role that staff can play here, because I did just hear Chad suggest that we may want to kind of go back and listen to this conversation and potentially offer some tweaks based on this conversation. And I want to make sure that that was actually what I'm hearing from you all.
That's what you're hearing from me.
Okay.
Then we have more thumbs up for that.
Okay, great.
I see Jeanette's hand up.
Yeah. Janet, did you want to?
Yeah, I think in terms of when you think about how you're going to structure these regional entities, and I think you need to clearly state whether they have a stick or a carrot, because they have to have something to motivate the community and the delivery system to work together. So either there's a threat from that entity, or that entity has some sugar to give that the community wants. And until we figure out which of those two levers the single payer wants to use regionally, I think it's going to be really hard to come up with a structure and a role.
Well, I vote for sugar.
You vote for sugar. That's just my two bets.
Yep. Yeah, getting back to money seems to be important. So
can I just say, I think that's a very important comment, and you need both. I mean, I've always felt like, frankly, in health, we have some people who are wonderful collaborators, but they're not good at confrontation. And we certainly have a bunch of people who are very confrontive and not good at collaboration. And you need people who are both. And in my mind, we need a regional entity and a single payer who comes into a room and says, look, I want to collaborate here. But, you know, if you're going to do this or this, then we need to have at it and see what happens. You know, I mean, so, you know, I can imagine where, you know, some of those issues would be around the equity issues and things of that sort. So anyway, I think you need both. I think an effective leader, administrator, et cetera, needs to wield both.
All right. Other thoughts on this? So otherwise we'll keep.
Well, I just don't see where the teeth are going to be. You know, I think that you know, I'm a believer in incentives being a positive notion, in rewarding and creating positive energy by doing something in a positive way. And that's the reason I mentioned sugar as opposed to the other. Right. You know, if it's the other, then you're going to have to empower the regions in ways that, you know, it sounds like we don't want to do, which is hold money back. And if we're not involved in holding money back, because we don't want the administrative overhead of doing that, then, so I know what you're saying, John, but I'm just not sure how you do that. Unless you provide, one of the things you can do is provide some governance of the regional entities in the single payer. So you can make sure that you have representation by each of these regional entities in governance at the state level. And that will, that structurally gets at that a bit.
Yeah, and you know, Chad, it's hard to do. I mean, I'll give you an example. In Massachusetts, when heart surgeons first started collecting data, it became clear that there was a community in Massachusetts who was having terrible heart surgery results. They kept saying they would improve. They didn't. And eventually, I don't know if, I'm sure the hospital had to agree to do this. They shut the program down.
Right.
They shut it down. Those surgeons went elsewhere. They figured out in the interim where heart surgery would go to. They started over. And within 5 years.
I mean, I support that entirely, John.
Yeah. Within 5 years, they had the most successful heart surgery program in the state.
Well, let's keep moving. We're a little about 10 minutes or so behind, but some of this we've already touched on a little bit. And so the sort of the next questions are related to structure. I think we may have already discussed the first one, but we didn't hear from everyone. Will there be one or more regional entities to serve a geographic region? So I'll stop there for a second. Chad, and then John, and then Bruce. Or I don't know.
I think they're just saying one.
Oh, one. Oh, okay. Just want to make sure. Communication is adequately translated here. Okay, everybody's saying one. One per region. Okay. Well, that's easy. We've got to catch up sometime. And then we had also sort of talked about this a little bit. Will they be required to be public, quasi-public, private, for-profit, nonprofit? I think we had decided it'd be public. We weren't exactly sure the exact structure, something to be determined, but we wanted to ensure they were nonprofit. Correct?
Yeah, I think the regional entity is going to need to be part of the structure of the of the single payer itself.
Yeah. Yeah, I mean, that's true. We decided that for the single payer, that it would be public and nonprofit, but you're saying that that would translate down to the regional expectation around the regional entities.
I've heard everybody say public, so I'd be voting for a public entity at the region.
Okay. Other thoughts on anyone, by anyone?
Yeah, I wouldn't add the words nonprofit. That's sort of assumed if it's public, right? Nonprofit has its own meaning of like an OPB, and we don't want an OPB.
Hey, Janine, this is Bartleman. Can I jump in with a question?
Sure.
If I was following the previous conversation correctly, it sounds like we're really not talking about these regional entities holding the money. And so if they're not, you know, the CCO-like entity, if they're not an insurer, if they don't have the funds flowing through them, why does their private or public or profit or nonprofit status matter?
Well, they might have money flowing through
Right.
them. It might be innovation funds or some other funds. I don't think I think we've established that the bulk of the dollars that go to pay providers wouldn't, but that didn't mean that there might not be some other dollars.
Well, Sarah, it's a really good question. We have had some kind of preliminary discussions, kind of like the schools. Some school districts are able to raise money in a variety of ways, you know, through grants, through parent donations, etc. And you could see that. I'm not sure at this stage we're willing to say, but maybe we should ask the group, should this regional entity be restricted to only doing business with from the single payer and be restricted to only revenue that comes from the single payer? You know, I need to think about that a little bit.
From my standpoint, I would say that we want an entity that is robustly moving to satisfy the values that we've put forward in the regional area, and if that means beyond the money in the single payer, I would support that.
Yeah, again, I see it as a sort of subset. So, you know, if and to Sarah's question, it matters because if you want them subject to public accountability laws like public meetings and public records and rulemaking and whatnot, and then like, you know, so if in a region, you know, Les Schwab's not around anymore, but if Les Schwab wanted to say the Central Oregon region, I want to have you really do this type of, I'm going to give you a grant from my family foundation to do something.
Right.
They would be talking to the regional entity, and the regional entity would say, okay, but the check gets made out to this public corporation, our statewide thing, and they would have to go to the statewide thing and say, hey, we got this opportunity for a grant in our area. Can we do it? We advise that we should, and we'd have language in what's the other side of that equation. Oh yeah, that sounds like a good extra funding opportunity. It doesn't undermine any of our statewide goals for you to do this pilot project that this family foundation wants to fund. Accept the money. The money will come to us, and then we'll write the checks. You know, the checks will come from us to the people performing the duties under the grant. So, you know, and then how we describe the entity, it'll have the ability to accept money, just like task forces often in their enabling legislation say it can accept grants and study things that happen. So,
well, and the other thing is policy. They've got to have a role in policy, and that policy needs to be transparent and representative. And so, you know, I think that's got to be very, very visible and easily seen.
And Sam has his hand up.
Thank you. I hope you all can hear me.
Yes.
Yes.
A few concepts. One is I'd like to see these regional entities being administrative divisions of the larger single payer organization. So all the reporting is upward to the our statewide single payer organization. Second, local grants. I would like to think that we would be able, the single payer system would not be dependent upon grants for improvements. But if a local entity has a local benefactor who's determined to donate, then I still think that should go through the single common pathway mission control of the state single payer agency.
As long as the money is devoted to that region, Sam. But if people are making a donation and the state is peeling off 30% for overhead and sending the money down, that's going to dry everything up in a second.
I don't see them. I don't see them necessarily peel it off.
Might I suggest we come back to this? I mean, let's face it, you all. We're talking about a company that could have $50 billion in revenue a year. The largest foundation, the largest philanthropies, the richest people in Oregon aren't going to likely get to money that should be as influential. I think this is a detail we can come back to. I agree, though. I was very impressed again in the trip to Eastern Oregon. You know, the folks at Lakeview wanted to improve their hospital, and they, you know, used the hospital district process. They put it to the voters. The voters voted a tax. The Eastern CCO supported what they were doing and helped in a variety of ways, and they really changed the landscape in terms of healthcare in Lakeview. And you know, they owned their healthcare system. And it was impressive to see, and I just think we've got to be able to do things like that.
Sam, you still have your hand up. Is there something else you wanted to add?
No, I'll take it down. So
okay, just checking. All right, anybody else? Deborah? Okay, so the last question was just, you know, as we know, some of the CCO development was related to variability. So, so if you decide that there's one per region and it's public, will there be any variability allowed as to the type of entity because of some uniqueness? And I don't know if you want to go down that road at this point, or that's something to be determined later. Bruce?
I would support in principle what Sam said, which was that they were administratively part of that they're all administratively part of the single payer in some way.
So in some ways, a subsidiary of, in a roundabout way.
I think to be determined, some regional office of regional entity, but I understand that there's variability in our regions. I'm not so sure we have to, it's appropriate to have variability in the type of entity that's, I think there needs to be some consistency there.
I agree. I have another question I'd like to maybe put in a parking lot somewhere or something, and that has to do with, I think in our brains, we're all thinking about the current existing regions in the state, and I think we should be open to taking a look at that and seeing whether that continues to make sense.
I would totally support that. And I would also caution that we don't want to set the regions. Just as a, you know, as a little history, I think when we initially started to talk about CCOs, we envisioned 7, consistent with the Dartmouth Atlas hospital referral districts. It made a lot of sense from how healthcare and dollars flowed in the state. Needless to say, we have 11 or 12 regions, And a lot of that was political considerations. And I think it's going to be very difficult to determine the boundaries of regions. And I would just recommend that that be a task that is given to the single payer once it's established.
Can I just add an element to that? Because it could also be, we're thinking geographic, but it could be cultural. We could have a tribal region or something like that that does the work on the tribes. So I agree, we can deal with it later, but I think we should think about this in a sort of more open way.
So I agree. Maybe the criteria, right?
Right. Actually, I think we had some of those kind of questions, but we decided that we'd, that's a lot of more down into the weeds at this point. But yeah, there would need to be some determination over how you would select them. We'll move on to the next slide, which just really gets again at the meat of the matter is, how the regional entity will work with the single payer entity. We've had some discussion about it really being administratively connected. So these are some suggested areas to consider. Single payer will contract with the regional entity to help support that convening of stakeholders in the region. They would be given a budget for investing, community investment. They'd be responsible for that county relationship with the single payer, which depending on how you set the regions, that could be one or more counties. And then there was some areas around some of the things that would be probably held at the single payer level, but that the regional entity would be advising on in regards to financial reporting and monitoring, solvency issues around risk-based capital requirements and monitoring reinsurance requirements, payment methodologies, some of which we talked about a little bit in the roles. And then, of course, then there's the question of who decides who gets to be a regional authority and what would be its selection process.
I would say that I don't know about the notion of a single payer contracting with the regional entity. If we're talking about subordinated entities, I don't think that would apply, but maybe I'm wrong.
So since they'd be a subsidiary, so to speak, or some other arrangement that any dollars would flow through, that they would not have some sort of contractual arrangements between themselves?
Well, not unless they were a completely separate entity. I mean, I suppose that cities have contracts or relationships maybe with the state, but I don't think it's really a contract.
But this is different than city and state. This is, a statewide thing with its regional office. I think of it like of a DHS office in Madras, Oregon. It doesn't.
I know, and it's that very example that causes me heartburn, Chuck.
Right. I mean, think about the Central Oregon example we just saw an hour or so ago. Think about those Central Oregon folks coming and saying, "Hey, we've been built to do this since 2011. We worked with Pacific Source. Now we'll work with you. And we're in the community. We know the community. The community knows us. I'm not sure I'm ready to say that all of these organizations should be, wholly owned and managed subsidiaries. I think the single payer should have an option to do something differently. In contrast, I'm not sure in Portland where you have, a pretty integrated market with, very competent health systems for the most part, that a fully owned subsidiary wouldn't be just fine. I don't know. I don't know the answer to that question.
John, to use your Central Oregon, the problem though is that Pacific Source is a carrier. And,
well, they wouldn't be any longer.
And so their interest in this would be different, let's just say.
Yeah, and if we want to have all the transparency and all that stuff, I don't think that means you lose that uniqueness. You know, I just don't think having them being a subsidiary or division doesn't necessarily equate with losing the uniqueness.
It doesn't, but
because we have to define that advice role and both sides of the advice role, right? Yeah. And as Chad said, you're taking out the insurers that are in some of the CCOs, the risk takers.
I mean, we're doing that, right? I mean,
right.
I think 770 is pretty clear about that.
Bruce, you had some?
No, I'll hold.
We hold.
I guess I would just comment that I think we have to be careful about getting too prescriptive at this point in the process. That I think we have to think about this in sort of some broad strokes. And I say that more for strategic reasons. As you put together a plan and it moves forward, you don't want to provide so much detail at this point that everybody's going to be unhappy with some piece of it. I mean, I think we have to outline something that's perhaps a little bit more visionary and that talks about, I don't know that we have to, we can talk about regional entities that meet a variety of criteria and kind of leave it at that.
So are you saying, Bruce, that then these words here probably are too detailed, or?
I think the responsibility words are good about when we start talking about what that regional entity looks like and who it is. I was just cautioning that perhaps we not go too far down that path.
Right.
So there was some issues with that you would contract with them. Do you feel comfortable leaving that language there at this point, or will Bill? I think the reason that we kind of used this was that there had to be some sort of, you will do this and we will do that kind of relationship.
The payer will work with the regional entity to convene stakeholders.
Okay.
That could be done through a contract, through a budget.
Or depending on how the structure develops. Okay. How about being given a budget? Comfortable with that?
Each regional entity will have its own budget.
Okay. You could, be even more vague as to what it's for. Each entity would have a budget. And then the one about the county relationship was to kind of have the local regional level relationship be super strong with the counties. That might be more challenging for just the single payer to do that directly. So that was why that bullet was there. I don't know if you want to say they'll be responsible or they will be work with. Obviously, they're going to need to work with. Is that enough regarding the counties?
Their work with local government and local government's work with the single payer will be through the regional entity.
What do others think of that?
Like that.
I'm not sure I know what that means. Can somebody say a little bit more, like, what is the work that we're envisioning here? Are we thinking about the county as a provider in this case, or something else?
There's another pandemic, or we have to start doing immunizations for something really fast, and we have to deal with the county health departments to help implement it. It's the regional entity that's having those negotiations for how it works with the single payer.
So this is the local public health authority, not necessarily the county mental health system.
It could be the county mental health system. Yeah. And the county mental system.
Yeah, I was very happy to see this in there, just because we really haven't talked much as a task force about the counties. And, some of the counties have hardly any resources for health. And some of the counties have enormous resources for health. some of those resources come from the federal government for other things, which I don't think we would want to interfere with, but we'd want to coordinate with. And so I potentially see this as a major role for the regional entity. I think that's been a challenging relationship to maintain. And everybody can understand why. It's because there's so much variability.
In Central Oregon, we have 3 counties, and there are a variety of sort of structures that have been put in place that allow those 3 counties to collaborate in a variety of ways, whether it be transportation or health or whatever. And it seems to me these regional entities should be the point at which all of the cities and municipalities and counties in that area convene to have a dialogue on health-related matters.
Which was sort of the essence of what the Central Oregon
yes,
evolved from, correct?
That's correct.
Yeah. So,
can I?
Sarah, is that?
Sorry, Janine.
Sure, go ahead.
One more thing. I think we didn't really necessarily go into the literature and all of the examples on this, but listening to this conversation, I keep thinking more and more that what we're really talking about is sort of the backbone organization concept that's coming out of the ACH and community collaboration literature. And I'm wondering if there's not some learnings there that we could lift. And I do agree with Bruce that maybe we're too far in the weeds and we can sort of set direction, but I'm suggesting maybe looking into backbone organizations as another way to help with some of that direction setting.
Yeah, I think that you can. I think our experience with working with ACHs and some of the challenges they're facing in Washington right now is that some may just disappear because of lack of funding. And so setting them up, trying to learn from that and the models in New York may be helpful to ensure that you were getting to something.
So is it helpful to state actually that we're not thinking about the regional entities as one time you exist for 5 years, you do your work and then you go away. These are permanent entities, right? And so they need to be sustainably funded. That's probably worth noting.
Yep. Yeah, because
also the ACHs never followed the collective impact model. So the ACHs never became a true backbone organization. They did.
Which is why I'm saying yes, we said ACHs, but I think looking at the true backbone model from collective impact might also be worth considering.
Yeah. I think it's a good idea.
So we swirled around it, but you want some adjustments to the line regional entity will be responsible? Any? We move with Chuck's suggestion was the local governments will work with the single payer and the local through the regional entities or with the regional entities.
Yeah, it should be low. If you assume that it's not a CCO just for Indian country, but for tribes, right? So if you assume that we're not doing that, it would also be, if it was somewhat geographically defined, it would be, and the tribal, local and tribal governments, they'd be the initial connection. I think because of the special relationship of tribes, it's also, the statewide entity has to have that special relationship that we talked about previously, but.
Okay. The whole section on advising, yay or nay, I think we sort of captured that earlier in the roles, and that maybe that is better where that goes. Or are there thoughts on anything? And some of this gets at solvency, how they're going to be paid. I think we talked earlier about perhaps advising and approving, a lot of things, including policy. So this may be a little more in the weeds here, but there probably is a role where these regional entities would be understanding their region and bringing that back to the single payer as the single payer sets policies and implements these correct?
You know, I prefer a language like participates with as opposed to advising, but because advisory feels a little,
Yeah,
I don't know, feels a little weaker than I would like, I guess.
works together with, participate.
Yeah, I was thinking collaborate because, yeah,
Yes.
I agree. We've got lots of advisory spaces here in the state that don't function very well in terms of their impact.
Right.
And that may, when we come back around to the original first slide that John had done, we had advise quite a ways, several places in there. So we may want to take a look at that as well for that adjustment.
Right. Yeah. I mean, realize the word collaborate means that both parties have something to contribute.
Right.
And which is fine with me, because I think the single payer should make a significant commitment to indicate that we want to be part of your community. We want to help the economy of your community. You know, we know we're 20% of your, I mean, here you have an organization that is, 15, 20% of their economy, maybe more.
And all of the innovation will come from the regions, all of it.
Well, Chad, my comment would be, I think in order for this to work, we're going to have delivery systems that will go back to being delivery systems. You've got to, Sam has said this, I think, a couple times lately, and has said it well. You've got to get out of the business of billing and collecting and taking people to collections. We got to get the delivery system out of that business. Got to get that money. And
right. I agree, John, but I think that we have to understand that we have to be creative. We have to think about other care providers and how does the state expand its provider group, and how do we tailor it, and where does this sort of innovation, and I think it's troublesome if we think the innovation is all going to come from the state. I don't think it's going to happen that way.
Well, I agree, but I kind of heard the opposite, that the single payer wouldn't be an innovator, and I think for us to succeed, the single payer is going to have to pull off nothing short of a miracle in terms of reducing administrative costs. It's going to have to be incredibly innovative, trustworthy to get the delivery system to,
Right. John, I agree, but I think we have to be careful not to get so focused on administrative costs that we lose track of the more valuable innovation, which is tailoring the delivery of care in manners which is more cost effective. I don't want to get caught into this kind of administrative is the holy grail, because that is not the holy grail. It's helpful, but thinking creatively about other ways to deliver care will deliver much more money into the system.
Well, we'll talk more. When 30% of your budget is going to billing, collections, information systems that support that.
Well, all right. I mean, I get what you're saying, but I also think that we have a lot of policies at the state level which memorialize certain delivery care patterns that are very costly and enhance certain groups over other groups. And we need to get at some of those things, or we'll memorialize an existing inefficient healthcare system.
I agree with you.
So I think for the last bullet, just to double check, I'm going to circle back around. I assume that from our conversation so far, that the single payer entity will decide who gets to be a regional authority. They'll set some sort of selection process and selection criteria, probably through some open, CCOs are procured currently through RFAs, and rather than a true RFP, but something like that. But I see nodding of heads on that one. So, I was going to check with Laurel in terms of if we need to provide time for public testimony. We're getting about 2:40, so we somehow have kind of gotten caught up. So
yes, so I know that Dr. Huntington would like to provide public testimony. Can I ask, is there anyone else on the line that's hoping to provide public testimony? If so, could you please unmute yourself and indicate? Okay, just okay. Dr. Huntington then.
And I think our next slide is wrap up and questions for the CAC as per usual. Thinking about what we talked about today, is there a specific question that John and others, since John sits on the CAC, can take back to the CAC that you need some answers or response before our next meeting, which is only 2 weeks away?
Yeah, I guess the obvious one is, what is their vision for the role of, the consumers, the end users with, whatever the governance structure is. Yep. How do they believe they should interface? What does meaningful engagement look like? Where does, the community's, voice in terms of, whether it's purchasing equipment, I don't know, whatever the decisions are, so that we know what their expectations are and whether we could either work to level set or we can, incorporate to figure out how we create a pathway there.
Yeah, Deborah, we do have a question from governance at the CAC, which meets on Monday. And it does kind of generally do that. And I think it'll be interesting to see how they respond, and then we might think about a more specific question, because again, my own belief is that there should be, incredible engagement with consumers from the top and all through the organization. So I think it's a good idea.
So John, do you see, I'm sort of wondering, does the CAC want to have as their primary entry into giving comment and whatnot through the regional entity, always with the right to go to the state one, but knowing that the regional entity is has an important say, that when they advise the state, there has to be good reason not to go against the advice. I'm trying to get a sense of what the CIC thinks about where they want to be putting in their input, that they want to be watching hearings that are happening in Salem, or do they want to be involved in hearings locally, or both? And in my vision, it would be it's primarily through the local,
right?
And that they feel good about that because we've written standards for how the state has to take that advice and can only deviate from it for some really good hard reasons, right? And that they wouldn't have to worry too much about statewide.
And Bruce, did you have a comment?
Yeah, I'd like broadly for the Consumer Advisory Committee to weigh in on what they think governance should look like, the type of people, et cetera. We've had a discussion about the balance between, consumer voices and those that are technically, have some technical background in healthcare. I'd love your thoughts about who should govern this.
Yeah, that has come up as part of some other questions, and I don't think you would be surprised to hear that many of them expressed real reservations about governance executives who made enormous amounts of money. There's a thing going on now in Boston showing how many board members who are in health systems have made enormous amounts of money on stock options and investments. And this is at Partners, this is at Mass General and the Brigham, these organizations that we all think are so wonderful, and the conflicts of interest that are there at the top are just sickening. And it's not all, but it really is sickening. to read about it.
I'd be interested in governance both at the regional level and at the single payer level.
In terms of kind of massaging the wording of how this is presented to the CAC, because I know that that's been kind of an ongoing discussion of making sure that we're pulling together questions that get at what we're wanting to get at. Are you asking about who sits on the board?
I think that was the original question from the last tag to go to the CAC, wasn't it?
Or do we feel like just asking them what are your thoughts on governance is sufficient and gets at what you want to get at?
You know, can I make one suggestion? I would like to invite them to come to a meeting, and you know, more specifically invite them and set aside 20 minutes and you know, let them engage with this group. By the way, I just want to mention that as chair, I appreciate that Sam has come, Sarah has come, and then participated in the discussion, and I think that's a good thing, and I appreciate them doing that.
Yeah, so I think to answer, so yes, I agree with you, John. And to answer your question, Laurel, I think again, you know, not to make the assumption that they all have the same definition of what governance is and how it functions at lots of different levels, right? Yeah. So that would be important to being able to elicit the information we need to be able to intersect it with all of those levels. So, you know.
So, I mean, so what if it was something like who holds leadership positions? Or something about leadership?
So yeah, so I would agree with that. And I also believe that it's also just sort of the piece that we were talking about in terms of how they infuse their ideas from the local to the regional, and you know, maybe the stopgap is if things aren't working out, they also have access points to the single payer. I don't want to limit their ability to engage because I think that they can inform the process, but we also don't want to create, you know, chaos where folks are reaching out all over the place and there aren't sort of structures in place. So I'm really fluid, and I would love for us to have that conversation, as John pointed out, to be able to identify that from their perspective.
So where and how best to infuse public input in the new single payer entity with regional entities? It sounds like the questions crafted around that. Other thoughts before we move to public comment with Dr. Huntington? All right. Want to go ahead, Dr. Huntington?
Yes. Can you hear me? Are you hearing two of me?
Only one.
Okay, good. I really appreciate the work that the TAG has been doing, and I'm very reassured to hear so many members of the TAG agree with avoiding risk bearing among middlemen and that providers would be paid directly by the single payer. Very reassuring. Shifting insurance risk onto providers of care and competition among risk-bearing entities introduces serious perverse incentives. Competing risk-bearing entities soon find that the key to economic survival is not to offer better benefits and improved access to care, but capture a healthier than average risk pool. I too like the idea of sugar rather than punishment, but the two are inseparable and gameable if money is the source of sugar and punishment. Warnings, probations, and if necessary, excluding providers sounds more appropriate and less gameable. For payment of providers, letting the region use its global budget and negotiations among providers in the community can make moot the discussion of fee-for-service versus value-based payment. Under a global budget, a region can use the best of each pathway of payment. For example, regions could use salary, or they could use fee-for-service based on a combination of time-based and expertise or training level. I have presented to the provider payment tag the flaws in the current value-based payment system now in use. As two other items, I wondered if Connecticut's experience with managed fee for service has been studied. I didn't remember hearing about that in the provider payment tag. And also offering Chunwei Chi, professor of Healthcare Administration International Track, as someone who can provide quite a bit of good advice on governance. Thanks for listening.
Thank you, Dr. Huntington. So just to kind of wrap up, I think our next meeting is, I don't know if, I don't have the date in front of me. Laurel, do you want to?
I think it's the 26th.
Yes, sorry, I was scrambling to get off mute. It is the 26th.
Monday the 26th, so not terribly far away. We will attempt to summarize what you said today. It's a lot of, I think, great conversation, and we'll have to see how it all sort of comes together as a summary and see what we want to adjust. And as we go further, now that we've had this session to think about, the next session is taking that issue of the public trust. How do you preserve, quote unquote, I think somebody said the lockbox, but it's also fiduciary requirements. So I think it'll also dovetail on some of this conversation of that relationship between the regional entities and the single payer some more.
Is there a report to the task force on the horizon?
Yes, thanks for bringing that up, Dr. Santa. We are hoping that we might be able to summarize the conversations that we've had to date and send that back out to you all. The 26th is before the task force meeting. The upcoming task force meeting is on the 29th. And so we are hoping to send some of this out to you in advance of the 26th, as we have been doing, and have that inform a more robust report back on the 29th. You all have made some real remarkable progress in landing some of these conversations, and we feel like it's appropriate to be sharing them again in a more robust fashion than just a quick report back. So we are kind of suggesting that this would be in essence a proposal preview is the terminology that we've been using with some of the other tags.
Yeah, because then following the 26th, you have another session. The 26th was the one we had added in extra, so we made sure we had enough time. And then there's still some things to think about in terms of authorities, and then again, another review of the overall proposal at our final meeting on late May, which would also precede the next task force meeting. So these next couple, we're starting to hone in on something concrete for you all to continue to advise the full task force about. Questions or other thoughts for today, from today?
Good discussion.
Yeah, I just want to thank the group. This is a terrific discussion, and staff did a great job of navigating through it. And again, thanks for comments from folks at the meeting, but not on the task force. Really helpful.
Okay. Well, with that, we'll give you an extra 8 minutes of your life back. And watch for some summaries coming your way in your emails. All right. Great. Thanks. Enjoy the sun.
Thank you.
Bye-bye.